This is the Celiac Project, two guys talking gluten-free. Just wanted to give a little disclaimer. We are not medical experts, doctors, dietitians,
Nurses,
bone experts, surgeons.
we're only experts at being celiac patients.
So enjoy the show. And if you're going to do any changes to your diet or need real medical advice, please go to the medical professionals.
That's what they're there for. We have an amazing treat for you. If you want to listen and watch this week's episode, you can go to youtube.com/@celiacproject and watch it there.
If you prefer, you can listen as you usually do. We hope to have some of our future shows on video as they are available, so look for that as well. Now let's get to the show.
Sounds good.
You found the Celiac Project podcast, Two Guys Talking Gluten-Free. I'm Mike.
And I'm Cam.
And who's joining us on the podcast today, Cam?
Today we have Dr. Jenny Jagers, who is a medical professional with celiac disease and also an advocate out of Canada.
Jenny is finding innovative ways to spread advocacy and educate about celiac disease. Let's get to the show.
Sounds good.
Cam and I are so excited to be joined today by Jenny Jagers. How are you today, Jenny?
I'm doing great. Excited to be here. Thank you so much.
Yeah, we're really excited to have you join us. You have a really interesting background, medical, and having celiac disease yourself. Why don't you share with our listeners a little bit about yourself and your celiac story?
Sure. I am both a celiac, so a patient, a chronic illness patient, as well as a medical professional. And I really like how my journey has been. It's a bit convoluted and it definitely wasn't a straight line, but I opened all the doors that I wanted to and could and explored all the avenues available to me academically. And I think that truly that's made a really big difference in how I go day to day. Started out regular, typical, normal university route, did my undergraduate, went to do a master's because just loved science. And then from there moved into a faculty concerned with medicine, so Department of Critical Care, and got my PhD and published a few papers. With that, you feel exponentially influential. You've got this audience that then puts your science to work. And so for me, that was really quite a pinnacle of achievement. That was something I really valued. And from there, I wanted to potentially pursue some surgical methods in pulmonary medicine. So went to medical school. Medical school and being a chronic patient don't really mix. And there was a lot of disadvantages for me being a chronically ill person as well as a medical professional in the capacity of day-to-day MD performance. So eventually I returned back to Canada, finished up some of my research projects, and now I work at bringing the science and the data about cutting edge therapeutics and technologies to specialists. And I work for a pharma company and it's been really lovely. And I get to lecture all the time to medical students across Canada and the US for celiac disease.
That's amazing. And do you mind sharing us too? When did you get diagnosed with celiac disease?
So I got diagnosed. I know the exact day. I almost know the exact time because I knew I had to wait to call one of my besties until she was done work. So I got diagnosed on May 23rd, 2003. So I have been a celiac for longer than 20 years. And I actually celebrate my celiac birthday every year because I think it's important. It changed the course of my life. So I was 21 and pretty sick when I finally got diagnosed.
So a follow-up to what you were saying, how things didn't mesh up or it wasn't a good mix to be in the medical community and have this illness, this chronic illness, celiac disease. Can you explain that a little bit more to our listeners?
Yeah, absolutely. So there is quite a disconnect between the amount of time and needs you have as a chronically ill person that have to do with disease portions and control and avoidance of triggers, and what you need to be doing either as a medical student or a resident. And for me, one of the biggest barriers was once I started rotations, no hospital has fast food that's gluten-free, that's ready to go for you. And if I left food in the fridge and anyone decided that my lunch looked better than theirs, I don't have an alternative. Additionally, the amount of studying and the amount of time out of your own home and a safe cooking environment that you have as you go through medical school and do all of your rotations is almost zero. So I wasn't able to prepare enough food for myself, and I was significantly far too skinny. And I was losing important amounts of body weight, healthy body weight at the end, and it just wasn't sustainable.
Yeah, Cam and I talk about that sort of, I'll say, irony that a lot of times, like when you're even hospitalized with celiac disease and the hospital can't give you food and you're there learning and studying, the lack of supports just from a dietary standpoint is staggering. And that must have been really hard for you and surprising that that was the case.
Yeah, I mean, to be fair, I thought I could do it all. I really did. Like I knew, and I had been through a pretty rigorous PhD. I took extra courses because I wanted to prove that I had all of the background so that when I went into medical school, I wasn't completely reliant on an undergrad degree that was several years in the past. And I really wanted to be up to date and I wanted to stay that way throughout the 5 years that I was there. And so I thought I could manage. I thought I was going to be all right, but there's just such a demand on new MDs and on students. And during the match process in your first year, you're essentially a gopher and a learner and a responsible, and you're also trying to keep up with studies and you're trying to read every possible exam guide. You are just run off your feet. And I mean, there's only so much a human can do, and there's only so much a body can take. And frankly, kudos to everyone who makes it, but the faculties and the division heads and anybody else, including student union, were fairly useless in helping me to get accommodations. And I understand it's a rigorous program. We want the best to become the doctors that we see because they need to be able to perform regardless of how busy they are, regardless of the stressors in their lives. So, I mean, I get it, but I'm also sad for it.
That's understandable. And I wonder too, if you had a student that was mirroring your path currently, what advice would you give them to handle it? Maybe different than you did or how you did it yourself?
Actually, that's so funny that you ask. I help occasionally because I used to be a tutor for when that company that I used to work for has aspiring medical students. I actually work to talk them through what they're going to write in their admission application for their letter and make sure that they know what it actually feels like for those first few years. And I share with them, and I'm really listening for their empathy and I'm really listening for what they think they can change and make better because I think those are key components to being a good physician. There's lots of things that I think I would be great at as a physician, purely and simply because I've been a patient myself and I know what doesn't work. But I do try and warn medical students. And most of the time, the warnings never get heeded because in order even to start applying, writing your MCATs, everything, you're ambitious. You're not going to give up on your dream. You're probably going to need to see it through yourself. And that's the kind of people we want, right? In medicine, you want those highly ambitious, internally motivated folks.
Definitely. I'm curious too, do you have any memorable stories of dealing with symptoms or like going through that, what it was like with celiac for yourself?
Yeah, if you had asked me that question 10 years ago, I would have given you a very different answer. But since I started advocating for celiac disease in a more public way, especially in an academic way, I've come to realize that all the stories I used to tell were based on luck and how lucky I felt to be diagnosed and how one surgeon being switched out for another just prior to the consultation resulted in me having a biopsy and not a colostomy bag. Like those kinds of things, those weird fated events. And it turns out that if I keep sharing stories based on luck, people are going to feel like they don't have enough luck to get diagnosed. And it adds to the feelings of defeat and being gaslit that we're mostly exposed to and experiencing when we're searching for what's wrong. And so I kind of refuse to share those stories anymore. And what I want to share now is a story about how when I lectured at UBC recently, I lectured for a class of very diverse class, everyone going into the medical profession. And the questions I got afterwards were not only about the process of diagnosis and not only about the qualities, signs, and symptoms, but about how they really felt to a patient. And I was so like impressed with our younger, ready to go students. And I was so impressed with their capacity and their mental health awareness and knowledge and the implications that they put seamlessly in to how they were asking the questions. And the men in that classroom were also impressive when they heard all of the differences between men and women and diagnostic rates for them. They were absolutely appalled and they wanted to know why that was, what had led to that, what can be done. So I was very inspired, and that is hopefully going to change how much luck you need to be diagnosed in the future.
That is such an interesting and important point to make, this sort of idea of luck versus like real knowledge in the medical community. I think all three of us were diagnosed, I don't want to make complete assumptions based, Jenny, on what you're saying. And I know Cam's story, and I certainly, didn't get diagnosed till I was 40. And it was, I will say, I didn't necessarily always think of it that way, but I think got lucky eventually that I got diagnosed. And it was really frustrating when I had symptoms for the majority of my life that it took to me being 40 to have that luck. So, why do you think this is that the medical community in general is having so much trouble identifying the cases of celiac that are out there, and how do we start changing that and get the diagnosis rates a lot better?
Yeah. Well, I'm hopeful that I can be part of that change. And I want to see that change within my lifetime. But medicine takes a long time to change. And there's a couple of reasons for that. One of them is that we don't want to ever do anything that's going to harm somebody. And so even clinical trials and bringing a new drug to market takes upwards of a decade. And that's because we have to verify the safety. We have to make sure that in the normal physiology it works, and in the disease case and long term. We also have recency bias, and we also have first exposure bias. When you're in medical school, if you went to medical school more than about 4 years ago, celiac disease was about 3 minutes in your MD training until you maybe got to gastroenterology as a rotation. And then maybe it came up, maybe. But there was this idea that it was rare, that was presented for years and years and years and years. And just think about the amount of things you could go to your family doctor with. And you think about how celiac has 300 or more signs and symptoms. You could literally be anything in their entirety of their Rolodex of disorders and diseases. You would fit into so many categories. And so it just makes it this kind of ether that you have to sort through. But if we step back and take kind of the larger kind of 10,000 foot view of this, one of the things that I think isn't being recognized is that celiac disease is so common that it's almost always going to be a win, right? Like you cannot be wrong that many times if you are just randomly applying, because 1 in 83 individuals in a mixed cultural group like Canada is suspected of having or will have celiac disease at some point. And even more of us, even up to, I think I've read numbers about 98% have at least one marker in the HLA DQ2, DQ8 genes. And so with that, I mean, Irish and Italian populations, some towns have like 1 in 5 people is celiac. I mean, if I was right 20% of the time on a pure guess, I mean, I'd be hopefully a lot more popular. That's a really good set of odds. And so doctors love to be right. We love to know things. We love to really dig in. And it's so easy with celiac disease. And we have a blood test for it. And in most provinces in Canada, that blood test also includes an IgA deficiency score. You're not going to miss. It's always going to be a win. But we have to get people to buy in on that idea. We have to show them the evidence, and we have to give them the motivation to do it. Right now, within our own system, our doctors are so overwhelmed that they can't hear us say it might be a big win. They don't have the capacity.
And that, yeah, that is unfortunate and sad. that that's the case. And when you were telling us some of those numbers, I thought to ask you as well, what about some of the discrepancies between celiac diagnosis rates and the prevalence of celiac disease in the general population?
Right. So the actual rate of occurrence for celiac disease in the mixed population is estimated to be 1 in 83. I've seen it a little bit lower, 1 in 80, but that has a lot more to do with cultural groups. Certain cultural groups are more susceptible. Like, for example, the Japanese population genetically has less chance of having celiac disease, but African and Indian populations, and specifically Caucasian populations like English and Irish, have higher rates, as high as 1 in 5. However, for every 164 celiac, only one of them knows they have celiac disease. And the rest are just accumulating intestinal villi damage, symptoms, other signs, living a not great, not balanced, not healthy life, and potentially mental health wise, really stressing about it, wondering what can be done, hoping for help.
Yeah,
A lot of
comorbids
people.
and
Exactly. And the comorbidity thing is its own entire complication piece. For example, there was a case that we were presented in medical school about a 24-year-old woman who had bumped a counter and broken 2 bones in her wrist. The answer for the class was osteoporosis. But at 24, no, the answer is celiac disease, but celiac disease wasn't even an option on the answer sheet. So it is that these signs and these symptoms end up getting labeled. And the underlying cause, because you go into the doctor and tell them one complaint at a time, because that's our system. And so you get symptom treatment. You don't get disease treatment. You don't get proper underlying diagnosis. We have so many things in our bodies that can go wrong if we're eating gluten and the body is responding to that in an autoimmune way. Every system in the body can be affected. So it's both masking, but also manifesting. We just have to choose to see it differently. We have to choose to recognize its commonality, and we have to choose to proactively find it.
Yeah, I certainly relate to everything you're saying. It's like at a certain point, they decided with me that I was a highly stressed out person and tried to deal with the symptoms rather than the underlying cause, which was celiac disease. Wanted to move back on something that you said, Jenny, earlier. Could we talk about some of the biases in getting diagnosed? What do you see as some of these biases that happen and maybe ways that we can address them and try to figure some of that out?
Well, I think I've experienced every single bias that can happen except those related to darker skin tones in different cultural groups, because I do fall into the Caucasian category. With that, when I was 4, I was pretty thin, pretty scrawny, and labeled failure to thrive. But everyone blamed it on me being a picky eater and encouraged slash lectured my mother on how to prepare a more balanced meal. And then when I was delayed puberty, everyone told my parents and me, don't worry about it. Kids hit their stride at different time, right? And then when I was 15 and I was dancing all the time, I was in 2 different kinds of dance and performing and doing competitions. And I was told that really active bodies just require more food. And then when I was focused more on the ballet type dancing, the body type I had was exactly the one they wanted to see from me. So there was this weird dichotomy as a teenage girl. Somebody asked me if I thought I might have anorexia or bulimia when I was 15 and complaining about feeling nauseated all the time and feeling like my body didn't want to eat, that I couldn't put food in. Then when I was 19 and taking 6 courses this semester at university, I was labeled type A and high stress, and it was probably just anxiety. So I fell into a lot of those categories. Additionally, there are signs and symptoms like canker sores that will get put off to, well, people just kind of sometimes have those. Just make sure that you're brushing your teeth. You can try a different mouthwash, etc. But those are one of the most common symptoms outside of GI and anemia. And people just brush those off. I think the bias also exists in male versus female. On average, men who report with a GI symptom will get diagnosed in as little as 4 to 6 years. But the average is 6 years because women take an average of 7 to 11 years to be diagnosed, even when presenting with gastrointestinal symptoms. But did you know gastrointestinal celiac disease, classic celiac disease, is only 34% of celiac? So even the way we think of it, define it, relate it, when we hear it from other people, we think, oh, they must have chronic diarrhea. Nope. 2/3 don't.
Right. And that's a huge one that I think we're trying to help break that stigma of it being GI. And it's so interesting everything you shared because my understanding has been that sometimes it's harder as a male to get diagnosed because males are more often won't go to the doctor and ignore some of the things. So there's some of that I think that comes into play as well.
I mean, we can't do statistics on diagnosis unless you end up being diagnosed. And so some of those behavioral patterns probably play in. We used to think that there was a huge discrepancy between males and females for celiac disease. Genetically, that's probably not true. However, there was a couple of papers when the idea of infertility started to first be associated with celiac disease, and undiagnosed women who couldn't get pregnant, or when they got pregnant, they couldn't sustain the pregnancy. And with that came this idea that potentially, if you were very celiac or severely celiac, then you as a fetus wouldn't make it. And that an undiagnosed mom eating gluten would affect the fetus. And with that, there was this idea that maybe more male children weren't making it because a lot of male celiacs are diagnosed in childhood with the classic signs and symptoms. The Canadian Celiac National Group actually ran a campaign featuring a young boy who did struggle with some of these biases to get diagnosed, but he got diagnosed in childhood. And again, their advertisement in their campaign was about GI symptoms. And so even as a celiac community, no matter what effort we're putting in, if it isn't balanced with how it actually shows up, we're reinforcing some of those biases.
I could not agree more with what you're saying about that we all get stuck. I think even those of us who are very involved in the community with the idea that this is a GI disease, which is very much not the case. And I'm so happy that you bring that up because I know that that's a big way that the public still sees it and even a large part of the medical community. So I know we're not going to solve everything today with how we help with, changing some of these perceptions. Obviously, biggest importance, I think, is getting those diagnosis rates to a much better place. Are there some big general things and maybe even some things that you've seen, Jenny, as you've been advocating and part of the community that you've seen that you're hopeful about and maybe some things that you think still need a whole lot of work?
Yeah, thank you for this question. I think that we have some key opportunities right now that every single person, whether or not you yourself are a medical professional, can help with. One of those is we all have this ability now to see when new ideas are coming out. And so when you latch on to a new idea, there's TikTok, there's Instagram, there's all of these other sites, there's YouTube, and there's all sorts of platforms. You can even subscribe to one and help support them by becoming part of their Patreon group. You can tell I'm not the tech savvy person in in my life, but with that, you've got the power to really understand new concepts and really grasp new knowledge, and you can pass that on. However, how we pass that on might be the make or break moment. And so, if I could offer some advice to people who aren't medical professionals but do know a lot about celiac disease, is that you stay up to date and that you know where there are public resources that are not WebMD and are not AI formulated, but are worthy of medical appraisal, worthy of medical reading. And so, with that, the national group, both in Canada and several across the US, all have for medical professional or for doctor sections on their website. And in there, they have some very good up to date information about both symptoms and signs for celiac disease, the diagnostic and patient pathways, and to biopsy or not to biopsy. Canada is one of the last first world countries to stick with biopsies after certain numbers are shown on blood work. And so potentially grabbing them from both the US and Canada might also help. And I think too, we forget sometimes that doctors have very specific training to think of options. So you might want to try employing some of the tactics that doctors use to learn about new things and to evaluate patient success and patient issues and underlying cause by asking, what do you think it could be? In medicine, we call this a differential, where we hypothesize as to how many options these signs and symptoms would fit into. And if they tell you, oh, I think it could be, IBS, or I think, your anemia could be something about like your diet. And then say, well, what if it turns out to be celiac disease? What did I tell you today would have fit that? Rather than reinforcing the negative by saying, well, why not celiac disease? All you're doing is getting them to tell you what doesn't fit. But what doesn't fit is what doesn't fit their understanding, their paradigm, their training. And if you have an experienced GP, you are probably benefiting so hugely from their years in practice, but not in this case. Not now, not with celiacs, not with the current numbers, not with the current testing. There was a study in Brazil and also one in Mexico of pediatrics. And the pediatricians were asked to identify certain qualities and signs and symptoms associated with celiac disease. It was pretty abysmal. It was not great. And I suspect if we were to repeat that, we would find the same pretty much everywhere. And it's not their fault. But if you can help them along the journey and you can rely on them for their medical expertise, not in the current facts they know, but in the way they're trained to think and their ambitions and their previous love of medicine and helping people and all of that, if you can call all of that back up, we'll make a lot of change.
That's great advice. It's interesting as you're saying that, doctors are human and they only have studied what they've studied, and some honestly have a blind spot. And I also love what you said, because I know when you're diagnosed or when you're doing inquiries for yourself to see if you have this or if you have been told that maybe you have it, you can go down rabbit holes and it can lead you into really, some sketchy information. There's really good information out there, and there's really stuff that's not grounded in science. So, like what you're saying is finding one of the big national institutions, if you're in Canada or the United States, that have everything vetted and grounded in science is the way to go. So you don't go down some rabbit hole and not get what you're looking for.
So there's also danger in just going on to a research site like NIH or something like that, because a lot of people in the public don't recognize that we have a hierarchy in our journals and where you publish matters. But when I say the white book in a certain area of medicine, everyone knows what I'm talking about. But I say that regular people style, nobody knows what I'm referring to. And so if you were to pull a journal article from something with a very low impact factor, nobody's really going to value that. It's a one-off, right? And one paper does not a science make, nor can it destroy one. But what does make a difference are systematic reviews and any sort of kind of up-to-date diagnostic criteria and testing paper. Those are the things that these national association and disease awareness groups are able to provide you. And that's what your doctor needs to get curious. That's what your doctor needs to literally get up to date.
And that was what was going to lead to my next question is what should people do if their doctor isn't to the competency level they want them to be, either in education or otherwise? Obviously, we would tell them to go find somebody new, but sometimes that's not always available for various reasons, location, insurance, all sorts of things. What would you give a patient advice for how they should help their doctor get educated?
First and foremost, nothing to do with the doctor. Don't stop eating gluten. You cannot be diagnosed with celiac disease if you are not eating gluten. The tests all measure damage. You have to eat gluten until you are diagnosed. And once you are diagnosed, go gluten free, 100%. There is no other treatment. But there is 0 point in eating a gluten free diet unless you have to. 0 point. Our flours aren't fortified. There's a lot of misconception about what the calories are and are not in gluten free products, but it's a lot more sugar and a lot more preservatives. So don't stop eating gluten. Number one piece of advice. Second piece of advice is try talking to your doctor in a different way. Think about what might be a barrier for your doctor or ask. Ask them what happens when you come in and you suggest something and they're shooting you down. What do they see the process as if they could do it their way? Because if your way's not working, just ask what they'd like to do instead. Remind them that there could be a differential they're not considering. Use the word differential. The nice call out to how we've been learning for our entire academic journey. The nice way to remind us that we might be cutting out an option we shouldn't. Let them know that there's celiac screening panels on regular blood work. Let them know that there's been campaigns to diagnose whole groups. There was just one last summer in Ontario, and it was 2 months worth of promotion of the celiac screening panel. Let them know without saying the words "you're behind." Let them know what's going on so that they can look it up. They can verify. And if they don't want to do the verification, or you suspect they don't or they won't for you, bring the paperwork. All of these things are national projects. All of these things are available from federal websites. Those kinds of things are outside of you trying to govern your doctor's behavior. They're outside of making your Google degree, bigger than their MD, right? So, I think we forget that they're just people and they're dealing with 700 things in a day and they're considering 80 things per person and they're not getting paid the way they should. I don't know a single doctor who's happy with the way billing works in Canada, and our student loans are enormous and it's so much stress when we're new. So I think that we just forget sometimes that it's impacting us. And frankly, with 146 celiacs, only one of them knows they're celiac. Chances are there's a bunch of doctors running around with undiagnosed celiac too. So they're probably brain fogged and fatigued, just like you and I were.
Very true. And if, let's say, now fast forward, that was such a great rundown and explanation for people. Now this patient is diagnosed and they're continuing care. How would you have them handle that?
So I think one of the most important things to recognize is when we are undiagnosed, we are mounting risk. So for every decade or so you are undiagnosed celiac, that first decade makes you 24% more likely to develop a second autoimmune disorder. Type 1 diabetes being one of the top contenders there. As well, you have other diseases that affect the bowel, like colitis, Crohn's, etc. And there's some genetic linking that goes on if you do have a lot of the genetic for those pieces, or if anyone in your family is diagnosed with any of those kind of inflammatory bowel diseases. Your second decade that you're undiagnosed will bump that to 34%. And beyond that, more than 55%. So your chance that your celiacs and your diagnosis is the only diagnosis you receive in the future may not be good odds. So you do have to stay vigilant about your symptom. And the best part is your TTG score will back you up. If you know that you are diligent in your gluten-free diet, as long as your TTG score works its way downwards, you're not eating gluten. It's when that TTG goes the other way that you want to be sure that you're vetting your diet and checking for minute sources. But I guess a myth about the TTG score, some people will never get to 0. And you shouldn't necessarily consider that to be a marker of success. If your score was 200 and 6 months later, your score is 180, look at what you did. You're gluten-free. It's awesome. Your body is healing. Because TTG is a protein that appears in our blood and we're able to measure based on the protection mechanism our body is issuing. I don't want my body to stop protecting me because I didn't eat something for a week, right? Even a year. I want it to stay vigilant. And that's what the intestine is doing. That's what the body is doing, your immune system. And so even though it's autoimmune, your entirety of your immune system isn't dysfunctional. So do stay vigilant, but getting your TTG tested more than once every 6 months is probably pretty useless. It doesn't move that fast. If you think that you had pretty big malnutrition, pretty big malabsorption for nutrients, get a bone density scan. Also important, if you are trying to get pregnant and you want to start a family, I guess also for males too, I shouldn't exclude them from this statement, go and get your hormones checked. See how you're doing reproductively. Do a double check. What's your BMI? Could you be healthier? What's your aerobic capacity? Are you actually breaking a sweat 3 times a week? What are you doing to get your body to a place where it can be healthy again? And just keep good contact with your doctor. Thank them, because it's a pretty thankless job sometimes. Thank them for figuring it out. Bring them new pieces of information. When I got diagnosed with celiac disease, my GP, when we kind of got together and talked about it, he had mentioned that there were a few more people he needed to talk to. And I just thought that was amazing because he and I had been on this journey together. And for him to come out the other side of that and make other people's lives better, and he sees all those people every single year, he's not going to forget that. That's exponential benefit to having been diagnosed and to have that information transfer. And that's how things really change. That's how things get better.
Yeah, that's wonderful. And that's a great point. I mean, I feel like after I got diagnosed that my doctor had this theory that I might have it, and it hopefully helped her identify other patients that were similar. And so it can have that exponential effect of just helping in the future. Jenny, this has been so wonderful talking to you today. Before we wrap up, is there anything that you want to share with our listeners that we haven't hit on today?
Yeah, I would love to tell everyone, if you even know at all, even if you're just beginning the diagnostic journey, if you know the word celiac, you are already lucky. You don't need to feel excluded from anything because you're now part of a club that helps you to stay healthy, helps you manage your body in a more specific, precise way that will garner more success for you. Becoming celiac, getting diagnosed as celiac, struggling to learn how to be a participating celiac in your gluten-free lifestyle, those are good things in the long run. Those reduce your risk. So many people go through life never knowing what is wrong. The fact that you even know the word celiac makes you infinitely lucky already. Embrace it. Just accept that you have knowledge about your body that initially probably isn't very fun, but it's going to save you a ton of pain in the future. It's really a good thing.
That's a really lovely way to frame it. Thank you so much, Jenny. Everything you shared with us today has been very illuminating, and really appreciate the positivity that you're bringing to the community as well.
Well, thank you very much for having me. I really enjoyed talking about bias. It's a topic I feel very passionate about, and as well celiac disease. And it's nice to be in a room where just a little bit of a hint of a struggle as a celiac is well understood. Thank you again.
Thanks, Jenny. Be well.
Yes, thank you.
Thanks for listening to today's show. If you like the podcast, please consider leaving us a 5-star review on Spotify, iTunes, or wherever you listen to the podcast. This will help other people find the show. Thanks so much, and we'll see you next time.
See ya.